All right. Okay, I guess we can sort of get started and yeah, all right. So welcome everyone to session 44 of MRF HIV STI Echo. This is a very special edition again of centering around COVID-19 vaccines and variants. And again, we want to thank Dr. Chris Behrens in Seattle, Washington for giving us this talk. And so it is a very consequential time. So the vaccine rollout in Trinidad has started. This is day 3. We've been vaccinating, aiming to at about 1,000 persons a day. So we're well and truly along with our AstraZeneca vaccination program. Also as well, our Prime Minister has come down with COVID at the same time. So all these things are battling for attention and for space in our minds right now. And we just want to spend a little time to wish our compatriots in the Caribbean and St. Vincent who are having a difficult time with the volcano that's erupting. I hope everything works out well. We all hope that they're all safe, and we hope that there are no casualties, that there is no major disaster coming out of this. So again, we want to thank everyone for coming. Remember to, if this is your first time with us, to type your name in the chat box and a designation. We're hoping to have a couple more guests, but as time goes on, we will see how that comes along. So again, thanks again. This promises to be a fabulous session. And Chris, I'll turn it over to you.
Okay, thanks very much. Happy to be here, and thanks for the invitation. So I am going to briefly review some of the more relevant issues, I think, around COVID-19, and I do want to leave time for questions and comments, so hopefully we'll have some rich discussion afterwards. Usual acknowledgements to our stakeholders and sponsors. I have no relevant financial disclosures. Hopefully by the end, you'll be able to review some updated efficacy estimates for various COVID-19 vaccines, talk about potential impact of the new variants, and describe some of the recent safety concerns regarding the AstraZeneca COVID vaccine that is currently being widely used in the Caribbean, including Trinidad, as Dr. Boyce just mentioned. So as far as the vaccines go, it's pretty astounding. We've got 86 vaccine candidates now in clinical trials in humans, of which 8 have been approved for full use, and a lot more in the pipeline. So it's kind of worth recalling that this effort started just over a year ago, and to be able to have any vaccines within a year of identifying a novel pathogen is pretty remarkable. And we have actually kind of a lot of vaccine candidates, as well as several that are actually quite good, far better than anybody could have anticipated. This is a kind of a overview, I would say, of of 6 of the vaccines that are currently out there, listed roughly in order of when they came out and how widely they're being used. And what's sort of difficult and confusing about trying to keep track of all this is that there are various ways to estimate the level of protection. There are obviously all these different vaccines as well, and then they're tested in different populations where there are different variants. And so I feel like, this is a table that I try to use to keep track of where things stand, but there are asterisks and adjustments, and it continuously needs to be updated, as well as quite a few question marks that still remain. Now, I do think it's worth pointing out that this highlighted in red is the figures we tend to hear the most. How well do these vaccines protect against any kind of COVID symptomatic illness, right? And again, they're extraordinarily effective. The 2 earliest vaccines that came into use, the Moderna and the Pfizer ones, these are based on a brand new technology involving messenger RNA, extremely effective against preventing symptomatic disease. The AstraZeneca one, a bit more conventional in its approach, adenovirus-based DNA vector vaccine. Overall, we're looking at 82% efficacy as long as the doses are separated by 12 weeks or more between the first and second dose. However, much less efficacy against the South Africa variant, and we'll talk a little bit more about that later in the talk. What I think is really worth looking at, though, is just how incredibly effective these vaccines are against preventing severe disease and death. So even if they don't, even if the vaccine doesn't completely prevent you from getting COVID, it's going to prevent you from getting very sick or dying, at least as far as we can tell. Now, I don't expect these numbers to remain at 100% necessarily. I mean, it's early in the game, and I suspect we probably will see cases where the vaccine fails to provide that level of protection. But so far, these vaccines look extremely good, including the AstraZeneca vaccine in terms of preventing severe illness or death from COVID-19. More interesting and a little bit more difficult to ascertain is how effective are these vaccines at preventing asymptomatic infection. So ideally, you would want your vaccine against any kind of illness to not only prevent getting sick with the pathogen, but also preventing you from actually carrying it and potentially spreading it to others. And the early emerging data look reassuring on this regard, in that these vaccines seem to provide significant protection against getting asymptomatic infection and being a carrier against spreading to others. These data are not as robust. There are ongoing trials trying to sort of better pin this down, but so far, the data are sort of pointing in the right direction that we would want. That would be very helpful for reducing the spread of the pandemic. What threatens to sort of upend the dynamics of the pandemic are these new variants. And the story of these new variants really began in South Africa in the Eastern Cape region in late October of last year, where it was noticed a unusually rapid growth of clusters in that region. Correspondence with scientists and epidemiologists in the United Kingdom led to the discovery of a similar variant, although one which evolved separately from the South Africa variant, that was also driving a surge in new infections there. And obviously there's been a lot of study of these new variants, and they have been found to have certain mutations, especially in what are called the spike protein on the surface of the virus, that make it more infectious and potentially, in some cases, more deadly. So the South Africa variant, as shown here, really rather quickly came to dominate infections in that region. It's probably not a coincidence that it came out of the Eastern Cape region, because there is a relatively high number of people with HIV there who are not on antiretroviral treatment. And one of the theories about how these variants emerge is that they evolve within individual patients who have immune systems that are not all that strong and are unable to clear the virus, which gives the virus more time, more cycles of replication to be able to evolve these mutant strains. Now, here is a picture, a model of the coronavirus on top, and protruding from it are these spikes, these sort of gray and blue clubs, they look like. And the tips of those spikes are what bind to the ACE2 receptors shown on the bottom in yellow and red, which line the surface of the epithelial cells to which the virus binds. And it's mutations in that spike protein that enable it to attach more efficiently to the receptor. So again, the UK and the South Africa variants evolved independently of one another. However, they do share certain common mutations in the spike protein. And the mutations themselves are actually denoted in the exact same nomenclature we use for mutations in HIV. So if you've ever looked at a genotypic resistance assay report for HIV, you know that mutations are listed with a letter, followed by a number, followed by another letter, where the number refers to the codon number of the gene sequence in question. The first letter is the amino acid that's normally found there, and the second letter is an amino acid that has been substituted as a consequence of that mutation. So one of the more notorious mutations that is found in both the UK and the South Africa variants is called N501Y at codon number 501 in the spike protein, where normally an asparagine residue is found. We now have a tyrosine amino acid. And interestingly, they've been able to establish the impact this has. Instead of having just one binding site, potential binding site to the receptor, as a result of that mutation, you get about 6 potential binding sites. And that might explain why the virus is more contagious. Now, the impact of the UK strain, the so-called B117 variant, has been rather dramatic. This is a time sequence showing how the percent of isolated strains in Europe has changed over time, such that now virtually all cases of COVID-19 in most of Europe are due to that UK strain that started out in just one small region of Great Britain. I would say there are now roughly 4 major variants that we're tracking and concerned about. The UK variant, which I just mentioned, as well as the South Africa variant, which I talked about. There is also a variant that has come out of Brazil, specifically Manaus, a large city kind of in the middle of the Amazon jungle. And then there are some variants that have evolved here in the United States, in California. And each of these variants has some concerning features. Chiefly among them, the fact that they are more transmissible. The UK variant probably 70% more infectious. South Africa variant estimated to be 50%. The others we're not quite so sure yet. What's also alarming about that UK variant is it is 60% more deadly, which is something that we didn't necessarily expect from evolution of this virus. The others, variants, not entirely clear whether they have the mutations have any impact on lethality. There's also concerns about the impact on vaccines, and specifically against the South Africa variant, for example. It's clear that some of the vaccines are less effective against that as compared with what you might call the wild type strain that had been the predominant circulating strain in, let's say, South Africa prior to that variant emerging. And then there's concern about the ability of these viruses to be able to reinfect people who already had COVID. So you may have heard about this report. The AstraZeneca vaccine was introduced to South Africa, or was, I should say, ready, being prepared to be widely deployed in South Africa. But a small study performed there showed that the AstraZeneca vaccine actually was not really effective at all in preventing mild to moderate COVID-19 in the vaccine recipients there who were being exposed to the South Africa variant. The Kaplan-Meier graph there shows basically a lot of overlap between the confidence intervals for the vaccine and placebo group. Estimated efficacy that came out of the analysis was 10% with the confidence interval crossing 0. So essentially, the AstraZeneca vaccine does not protect you against the South Africa variant strain of COVID, at least insofar as preventing mild to moderate disease. Now, it's worth pointing out, and I think this is very important, this study was not powered to detect any difference, to document any potential protection against severe disease or in reduction of transmission. It involved only about 2,000 individuals who are all relatively young and healthy. So they simply couldn't establish whether or not this protects against severe disease. Nevertheless, South Africa decided to simply not proceed with using the vaccine there. So this is kind of a summary, a fairly technical table that's trying to summarize some of the more detailed knowledge that we have about how well these variants do against the various vaccines. I've sort of outlined that in the blue box, as well as some other data regarding the key mutations and where it has been reported. So true vaccine efficacy trials have shown that the UK strain, fortunately, appears to be relatively sensitive to our current vaccines, with minimal decline in the effectiveness of the AstraZeneca vaccine, for example, where it's been studied. The South Africa strain seems to be a bit more potentially resistant to the vaccines, and the Brazil variant, we really don't know yet, but we have some sort of in vitro, some test tube type data that suggests that the vaccines are likely going to work against that strain as well. Now, speaking of the AstraZeneca vaccine, I know Trinidad has been rolling out its use, and what's been making the headlines lately are these concerns about possible association with blood clots. And it's a rapidly evolving situation. So I'm trying to give a snapshot of where things stand as of today. This made the news just a few days ago. The European Medical Agency deciding that, yes, these unusual blood clots associated with low platelets are indeed a true side effect of the vaccine, albeit a rare one. And broadly speaking, they think that the benefits of the vaccine still outweigh the risk. Now, what blood clots are we talking about? Well, we're talking about some potentially kind of scary blood clots that involve what are called cerebral venous sinuses. The cerebral venous sinuses are these, you can think of them as very large veins. Technically, they're not veins like other veins in your body due to some subtle differences in the endothelial lining. Nevertheless, they drain blood and CSF from the brain down towards the inferior vena cava. Clots in these, blood clots in these sinuses can be devastating, actually, because you're in an enclosed space housed within the skull. There's no room for the increased pressure to go, and so it can cause brain swelling, brain edema, infarcts, and subsequently serious nervous CNS sequelae, including death. The other clots that we're seeing are in the splenic bed. The splenic veins are a drainage system serving predominantly the gastrointestinal tract. And so these are basically the symptoms that can be seen when you get clots in either of these two major venous drainage systems. The clots can produce shortness of breath, especially because clots in the cerebral venous sinus system can break off and go to the lungs, much like a DVT clot can, producing shortness of breath, chest pain. Clots can occur in the legs as well. A mesenteric thrombosis in the splenic system can cause stomach pain. Symptoms directly attributable to the cerebral venous sinus thrombosis would include severe headache, blurred vision, altered mental status. And if there's this disseminated thrombocytopenia or low platelets, you can get a lot of hemorrhage and bruising of the skin elsewhere. Potentially a very serious complication, and there have been deaths reported from it. The literature is just starting to come out. This was posted a few days ago on a preprint server in which the researchers based in Germany think they have identified the mechanism of this, and it's basically a disorder a lot like heparin-induced thrombocytopenia and thrombosis syndrome, also known as HIT. These investigators basically reported on detailed data from 9 patients who had suffered this complication after receiving the AstraZeneca vaccine. And they detail in this table where the thromboses occurred. In most of them, it was, well, in all but one of them, they picked it up as a cerebral venous thrombosis. There was also a splenic vein thrombosis. And the bottom line, as you can see, is that 4 of these 9 cases were fatal. So it is a very serious potential complication. Now, the mechanism that they propose, and they have some, I think, solid evidence to support this, is one that is very similar to what I mentioned, heparin-induced thrombocytopenia with thrombosis. In HIT, heparin that is administered can bind to a certain product of platelets. That complex generates the production of antibodies that unfortunately cross-react and activate platelets in various parts of the body that then result in thromboses, blood clots, as well as basically using up and depleting the platelets, hence the acronym. And this appears to be the pathophysiology that's going on here. They have found that in rare cases, administration of the vaccine can result in the exact same kind of antibodies that recognize heparin PF4 complex and would then therefore presumably use the same pathophysiologic mechanism to trigger an aberrant platelet activation and clotting cascade. Now, this has been given a proposed name of vaccine-induced platelet immune thrombocytopenia. And the European Medicines Association had a press conference just on Wednesday, giving some updated numbers. Within Europe, they had received reports of a total of 169 cases of cerebral venous sinus thrombosis, 53 cases of, I'm sorry, that's a typo. They call it splenic. It should say splenic vein thrombosis. But it's important to keep in mind that this was out of a population of about 34 million people that had received the vaccine. Now, they based their estimate of the incidence on data from Germany, where they felt like they had, the most robust data, and they estimated, and here I quote, one in 100,000, or maybe a little bit higher, is what they said. They have not been able to identify risk factors. They have seen these events in all ages, in men and women. I think obviously, you have to wonder, well, people who have underlying coagulation problems, are they at increased risk? Anybody who's had heparin-induced thrombocytopenia before, are they at increased risk? But it's just too early to know. Now, as a consequence of that, you may have heard that UK, for example, is now suggesting that individuals under age 30 perhaps should not get the AstraZeneca vaccine, perhaps should get a different vaccine instead. The reasoning behind that, it basically comes down to a balancing of risk-benefit ratio. These were data, presented by the UK to sort of justify or support that recommendation. And basically, you look at the potential benefits of the vaccine on the left side versus the potential harms on the right side. Benefits, of course, reducing risk of COVID and serious illness, versus that harm being specifically that of these blood clotting disorders. And you can see at younger ages, less than 30, the risk versus benefit is really just about even, right? But as individuals are older, well, their risk of serious complications from COVID increases dramatically. The risk of developing this clotting disorder might go down slightly. I think, these are not firm numbers, right? These are very early data, but this is kind of a back of the envelope calculation, as it were, that I think helps to reflect the thinking that goes behind that recommendation. And similarly, you can look at, numbers of ICU admissions due to, versus the harm due to the vaccine. So sort of on when looking at the impact of on hospitalization use and resources, again, you see the argument that for anyone older than 30, the benefits, both individually and public health wise, far outweigh the risks associated with this side effect. So I'm going to stop there and open it up to questions and discussion. I want to leave plenty of time for that, and address any other topics people might want to talk about.
Thank you very much, Dr. Behrens, for that wonderful conversation. So it's always really interesting how quickly things change, because the last time we had this conversation, there was all this new data about thrombosis and risk of thrombosis. So I'm just going to open the floor for any questions. If you can't speak where you are, please feel free to type in the chat box. But just a preliminary question from me then. So what would be the implications of that new recommendation? So let me remove this temporarily so that you can hear me clearly. Of not vaccinating the under 30s for achieving herd immunity, because based on the population dynamics of each individual country, that not vaccinating the under 30s might be a significant part of their population, and if they remain unvaccinated, does that suggest, if there is access to just say this one vaccine and not very much else in terms of availability of vaccine product, what does that mean in terms of herd immunity and reopening the country's economy and that sort of thing?
Yeah, I think that's a very good question, and I think there's no question about it. If you stop vaccinating that age group, you delay the time, your timeline for achieving herd immunity. And just to tie it in with the early discussion of the variants, it feels like we're in this race of the vaccines against the variants. The variants are clearly more transmissible. Some of them are clearly more deadly, and are, obviously there's multiple interventions we can do, and we need to be doubling down on all the non-pharmaceutical interventions to reduce the risk, like masking, social distancing, et cetera. But we also have to acknowledge, frankly, there's a lot of COVID fatigue out there, and people are really tired of, the lockdowns, the social distancing. And So the vaccines are such an attractive way out of this, right? And we are seeing that, you know, vaccines are very likely having an impact on reducing curbing the epidemic in many parts of the world where they, like Israel, where they have succeeded in vaccinating a large proportion of the population. So if you step back from vaccinating a large segment of the population, especially a younger population that are more likely to be socially mixing and potentially spreading, you see how that could really set back your efforts to curb the epidemic and delay, you know, any potential reaching of herd immunity. And I think that that risk really has to be, frankly, acknowledged. I think, you know, the United Kingdom, I don't know exactly what other vaccines they have, but I think they do have access to other vaccines. So it makes it a little easier for them to suggest, okay, we'll just use a different vaccine for people under 30. But if you don't have access to an alternative vaccine, that's a much, that to me seems like a much more difficult, you know, recommendation to make.
Just so thank you again, Dr. Behrens, for that answer. Question from Sharon. What is the average interval between vaccination and development of blood clots? And did blood clots happen after the first doses only or after both first and second doses?
Oh, wow, these are great questions. And I don't know the answers. I'd have to dig into, I wonder if that paper that showed up might have it buried somewhere in there. But the short answer is I don't know. I do know with the heparin-induced thrombocytopenia, it tends to happen within days of receiving the heparin. So my hunch is it's probably something that happens fairly quickly. I don't know, and hence I would expect it maybe to be in the first few, you know, after the first dose. But I don't know, and that's maybe we can find the answer to it and get back to you.
Just a little question, Doc. Does the vaccine confer any immunity against COVID infection? Because at least I know a few people were vaccinated and within about 3 or so weeks, they were diagnosed with COVID. If it doesn't, how then do we hope to achieve herd immunity?
Mm-hmm. Well, broadly speaking, the AstraZeneca vaccine is very protective against getting sick with COVID. And, but, you know, these estimates are based on what happens after 2 doses, right? We're starting to see some estimates with some of the other vaccines regarding how much protection there is after just 1 of the 2 doses, but I have not seen much. I haven't seen those data with respect to the AstraZeneca vaccine. If I, let's see, if I share this again, maybe we can go back to the data. Yeah, so this is our vaccine dashboard. Broadly speaking, the AstraZeneca vaccine is 82% protective against COVID-19 illness, and 67% against asymptomatic infection. So it is strongly protected. Now, it did not fare so well against the South Africa variant, as I mentioned. But even then, there's still some caveats that it may still provide protection against severe disease. So I think it's, you know, let's not, it's worth keeping the perspective that these are very rare side effects and that broadly speaking, it is a very effective vaccine. I hope that answered your question.
Yes, it does. Now, another question is, there are few people who are more predisposed to developing blood clots without any COVID. Let's say people with nephrotic syndrome with maybe raised D-dimer levels. Would you recommend such people to have Astra vaccine?
Well, so right, that's a great question, and we don't have enough cases, enough data, enough analysis yet to say who is, if anyone, is at higher risk for this. What are the risk factors for developing this this serious side effect? It would seem possible that increased coagulation or coagulability disorders might put you at risk. I would think that anybody who has had heparin-induced thrombocytopenia with thrombosis in the past would be at increased risk given what appears to be the very similar underlying pathophysiology. We just don't know that for sure. So I guess if I had a history of that, or if I had some sort of clotting disorder, I would personally be reluctant to get that vaccine until I knew more.
Okay, thanks.
The hit can be treated with IVIG, for example. So I think we're gonna be hearing more about possible treatments for this should it occur, which would hopefully lower the fatality rate if people are very sensitive to possible side effects, and if we're prepared to treat the condition early, we might be able to reduce the more severe consequences of it.
Thanks, Dr. Behrens. Dr. Boyce here again. A question has been kind of bouncing around inside my head with respect to the fact that the AstraZeneca vaccine is less effective against the South African variant. So that even if there is a population that is highly vaccinated using the AstraZeneca vaccine, if there's an entry into that population of someone or persons carrying that strain, that population would not be as effective, would not be as protected against spread, propagation, let's say. But yet, they would still, or they may still be protected against severe outcomes, even though we're not quite clear about that. How do we think long term with respect to, given how a vaccine rollout is going to look like, given the product we're going to use, do we need to think, or do countries need to think about limiting entry into the respective countries when they're reopening the borders after there's been sufficient vaccination? As in restricting entry from persons where the South Africa variant is prevalent until we know more about how protective the vaccine is against actual development of severe COVID. Because if it is that you're not protected against the severe variant, and then some of the South Africa variant enters the country, and then all of a sudden you're sort of back to square one with respect to COVID running through a country again and having to lock down. What would be your thoughts about that? Because I myself, I'm sort of a bit confused about how that would work, how that could work.
Well, I think it's a legitimate concern. I think we lack enough data to clearly answer that question. You'd really like to see more data with respect to, for example, if it turns out that the AstraZeneca vaccine provides, in fact, very high level protection against severe COVID illness or death. And so then, the South Africa variant, let's say worst case scenario, comes to Trinidad after you have managed to vaccinate a very high proportion of the population. Well, then it might look more like, okay, a bad cold is sweeping through the country. And that's not all that big a deal. And so maybe it's not worth, keeping the borders sealed just to prevent a whole lot of people coming down with, a cold, right? And that's why I think it's so important to know how well does the AstraZeneca vaccine protect against severe illness from that South Africa variant, right? Hopefully we'll get some information about that. I'm not sure. I don't know if we will though, because again, South Africa basically halted, stopped using that vaccine before they even really got started with their campaign. So this may be, at least for now, it's kind of an open question. I would say it's a legitimate concern. But on the other hand, it could turn out to be overly cautious to keep borders closed, even after you have vaccinated a large proportion of the population, just to keep out, let's say the South Africa variant.
Given the difference between COVID and other viruses, what population do you think needs to be vaccinated before a country can think they're safe?
What percent?
Yes, what percent? Because I've heard figures like if you vaccinate 20% of the population, then you're okay. Is that really true?
That doesn't seem right to me. Generally speaking, when you're talking about like a highly contagious, disease that it can cause an epidemic like this, you want to achieve herd immunity so that basically, even if the virus infects an individual here or there, there's virtually nobody else for it to infect subsequently. And so you cannot have propagation of infection and you abort the epidemic. The level of herd immunity required for this particular virus, I've seen estimated at 70 to 80%. And herd immunity can be achieved through vaccination. It can be achieved through enough people getting sick with it and having subsequent protective immunity, or some combination thereof, which is basically what I think pretty much every country in the world is looking at, going to be some combination of the two. So again, the estimates I've heard from Tony Fauci, who's basically the person I trust more than anyone in this regard, is you're going to need 70 to 80% herd immunity before you can count on having a population that is, shut down the epidemic, so to speak. And it's not that easy you can track what percent of the population you vaccinated. It's a little bit harder to know exactly what percent of the population has actually had the virus unless you do some sort of widespread, serologic testing for evidence of having had infection in the past. You sort of take, let's say, a random sampling of people across the country, test everyone, try to get a sense of how many people have had it. Coupled with that, you have to have a sense of just how protected they are against reinfection if they have had it. And that's where the variance comes into play, because we know that the South Africa variant and the Brazil variant appear to be able to reinfect people who have already had COVID from a prior version, a different variant. So you really start to get into the weeds with these different variables. But 70 to 80% herd immunity is the best sort of estimate I can give.
Two questions. One, should women on oral contraceptives take the vaccine? And second question, is there any way to identify persons who are more likely to develop the high-risk blood clot side effect, either through platelet testing or some other screening prior to vaccination.
Right. So the second question first, we are not aware of any, we don't know what the risk factors are. My hunch is we will, with more experience, research, et cetera, we will probably identify risk factors, but right now we just don't know. Which is probably tied into the question about hormonal therapy, birth control, oral contraceptives, or other kind of contraceptives. These, some of those are associated with a slightly increased risk of thrombosis. So obviously it's a concern with being on contraception, somehow increase the risk of developing these blood clots. Not at all clear, conceivably, but it's also very possible that the whole pathophysiology of this is so distinct that it's actually not a risk factor at all. It certainly hasn't come out yet, but I think the numbers are too small to exclude it as being a possibility.
Okay, thank you again. Not seeing any more questions just yet. So just so I keep getting this question from our patients. So I just wanted to ask the question again, because I see there are a couple of advocates here with us. In terms of safety in persons with HIV, there is no evidence to suggest there is any risk to persons with HIV to take the vaccine. Would that be correct?
That is correct. Right. We've seen no safety concerns for any of the vaccines, including AstraZeneca, for people with HIV.
Is that related in any way to the level of their CD4 cell count? Let's say somebody is HIV positive and their CD4 cell count is 110. Would they still be eligible for the vaccination?
Yes, and I would say those individuals should be prioritized for the vaccination if possible, because there is some evidence that people with advanced HIV, like low CD4 counts, do have worse outcomes with COVID. So I think it's that much more important to try and protect them against it. You can also make the sort of public health argument that, you know, as I mentioned, it's thought that these variants may be evolving in individuals with compromised immune systems, whose bodies allow multiple replication cycles of the virus, which gives the virus the opportunity to develop these mutations. And so perhaps in an effort to prevent the emergence of variants, we should be prioritizing people with compromised immune systems from getting the virus as well. But there is no evidence that the vaccines have a worse safety profile in those with decreased or impaired immune systems from whatever cause. In theory, it's possible that the vaccines might not work quite as well in people with compromised immune systems, but I've seen no data to date, you know, supporting that. It's more of a theoretical concern.
Okay. Thank you again. Slightly unrelated question, because let's just shift off the question of vaccines a little bit. So when you spoke about persons who are immunocompromised, you know, the virus having the ability to have multiple replication cycles or so, is there any evidence of, or are there any agents currently in development that actually target viral replication in the same sort of way as antiretrovirals do? And how far along are any of those directly acting antivirals in terms of aborting viral replication and so forth?
Right. So I believe remdesivir is sort of something along those lines. That was a treatment that was developed for people with COVID, but it has some impact, but it's not all that dramatic. Okay. We don't have treatments that are as effective at interrupting the SARS-CoV-2 life cycle as we do for HIV, for example. Not, you know, there certainly have been attempts to identify those, but we're just not quite there. And so our treatments of established, you know, SARS-CoV-2 mostly at this point still rely on what we would call supportive care, trying to, you know, oxygenation, you know, proning, fluids, trying to basically support the body's own ability to recover from the inflammation and the damage. And we have medications that kind of play, you know, that I think sort of nibble at the edges. I think the anti-inflammatory for severe cases like dexamethasone, that has a pretty profound impact. But in terms of medications that act the way our antiretrovirals act against HIV, we're not really there yet.
I think maybe one final question before we close. Some of the data in persons with HIV with respect to risk factors of developing severe COVID, they suggested, well, the data elements suggested that tanofavir was protective against developing severe COVID. Could you just speak briefly about whether or not that is actually anything to do with tanofavir itself, or more to do with issues that might have surrounded the reasons why someone was on tenofavir?
Right. Yeah, good question. I have to admit, I remember seeing that early on, and then I thought I saw that, you know, with more analysis, they didn't see tenofavir really falling out as being all that protective, if at all. Having said that, I haven't looked at that question recently, and I don't know what the latest. I would think, you know, that if tenofavir had truly emerged as being strongly protective against COVID, that we'd be hearing more about that, right? That it would really be in the news, it would be in the literature. So the fact that I just don't think it's out there makes me a bit skeptical that it plays much of a role. But I can't speak with 100% confidence on that.
Is there anything we should be worried about concerning RNA-based vaccines?
Well, so very good question. I think other people have asked, right, is there something about, you know, the adenovirus vector that is responsible for this? And I don't think anybody really knows. Right? It's not, we don't know what is the antigenic trigger for this VIPIT syndrome. The way, right, we've been able to work it out pretty clearly for HIT, but we don't know if the trigger here for this aberrant cross-reactive antibody process is the adenovirus vector, or something in the DNA, or something else. So I'm not enough of a sort of, you know, vaccine specialist to comment, other than I think we just don't know.
Okay, well, I think if there are no other questions, I think that's, we'll probably wrap up the session. Again, thank you, Dr. Behrens, for giving a wonderful presentation. Thank you for fielding all the questions. I mean, there's always so much new information coming along, and new concerns and new answers and new data. So thank you for lending us your time and your expertise in this manner. And thank everyone for coming. Thanks for all the questions you gave. So that's, I think, it for this session. I want everyone to be safe and well. I think at MRF, we're supposed to be going for all vaccines next week.
Next week,
So all
some
looking-
of it.
So, so I think we're all at least looking forward to getting to putting this COVID in the annals of history and getting it behind us at long last. So everyone, in the meantime, stay safe and well, and we shall see you again in another 2 weeks' time for another episode of MRF HIV STI Echo. And again, be safe, be well, have a wonderful weekend, everyone, and take care. And just a quick note, don't forget in the chat box, the session will be on the YouTube channel for any of those who want to take a look at it later on or to pass on to someone who may have missed the session. Thanks so much again.
All right. Thanks, everyone.
Bye-bye.
Thanks.